All right. Good evening, friends. Welcome to yet another episode of this Gujarat WhatsApp Pediatricians webinars. Today is, by the way, 14th episode. We have had 13. Sorry, this is the 15th episode. We had 14 so far in a row, except the one during the election time where we've taken a break. And of course, as you know, Gujarat Pediatricians have been conducting these online webinars initially on WhatsApp, what we call WhatsApp webinar, and now after that webinar during COVID time, especially, it was a lot of help to a lot of people. So with that, today, of course, we have a deviation so far. Myself and Dr. Bajania have been moderating all the sessions. We have handed over this time the task to completely a specialist neonatologist, because today we are discussing the PERS in neonatology. So we have Dr. Ashish Bhai from Ahmedabad, our very, very close friend, who will be moderating, and we have very eminent two experts who are themselves like teachers of teachers in neonatology, Dr. Naveen Jain and Dr. Sanjay Wazir. And they'll be introduced, of course, by Dr. Bajania in short time. We also like to thank the Zydus vaccine for are giving unrestricted scientific grant by sponsoring this link for each of the webinars. So with that, I would hand over to Dr. Bajania. You introduce Dr. Nilam Mohan is with us, our president-elect, very dynamic person and a great friend and a personal friend. So please introduce the other dignitaries who are on the Zoom link, and then introduce the speaker, and then hand over to Dr. Ashish.
Yes. Thank you, Dr. Nitin Bhai. So good evening, respected seniors and dear friends. We are back again. Like every month, we are coming with a quality academics. So this time, Dr. Nitin Bhai suggested that neonatology was long due. And we requested all our three eminent neonatologists that please prepare in a way that it could be of help to a solo pediatrician, especially those who are practicing in periphery, an important pulse. I welcome our President-elect, Dr. Neelam ma'am, for our program, and we are privileged and blessed with your presence, ma'am. Now, today, Dr. Ashish Mehta, sir, will moderate, and he is a very eminent neonatologist. In fact, he is the face of neonatology in Gujarat, apart from being his stature at national level. Apart from his qualities, he is a very, very humble person, always approachable, and he runs his urban neonatal care center. And more than 60, 70 already fellows, they have been out from his center. So he's a great academician also, and I'm very sure that he'll moderate session and make it a very vibrant one. We have two eminent neonatologists. One is Dr. Sanjay Wazir. He did his DM neonatology from Chandigarh and 18 years of neonatology practice. He has so many credits. We won't go into the detail. Dr. Naveen Jain, again a very, very modest person. He's from Trivandrum, and he's the editor quality manual of neonatal newborn care SAE. Plus, he has got also so many credits apart from being best teacher award. And as all will agree, all our three neonatologist friends, apart from their academic qualifications, they all are very nice human beings and humble persons. So I welcome all friends to this academic feast. And I would request Dr. Neelam ma'am to bless us because she's here. Nitin bhai, unmute, please.
Oh, Dr. Nilam
Thank you.
gives a blessing. We also have some other eminent personality. We have Dr. Guru Prasad, the Vice President from Central Zone. From IAP, we have Dr. Alok Bandari, and we also have Dr. Sandeep Trivedi. Welcome, all of you. Yes, madam. Dr. Nilam, please go ahead. Give your
Thank you so
blessings.
much. Thank you so much, Nitinji and Ramesh. And it's indeed a pleasure because both of them, as they mentioned, they have been very consistent academic program that have been performing, though for some reason it's called as the Gujarat WhatsApp group, but they seem to be more popular pan India, and small steps taken really sometimes make a big impact. I'm sure these were the steps that we started with a vision to bring about together the pediatricians in Gujarat. But somehow, as Rameshji has mentioned, not only are the speakers today, whom all of us are familiar with, but also both Nitin and Ramesh, in continuity with what Ramesh said, he was praising them and said that they are lovely human beings with good heart. And I would extend the same to the two organizers, both Nitin and Ramesh. I guess more than their performance, they are genuinely popular for their humility and for their niceness. And what to say about Nitin? I mean, I've heard in so many places, and I wondered why people call him Yaron Ka Yar, Raja Ka Raja. Never understood. But I guess now, becoming a president elect, I see that he is very popular in all groups and has been a past president of IAP, whom all of us are proud with his diligent performance and consistent academic performance, versatility, whether it comes to vaccine or hematology, but pretty popular calling a spade a spade. So I guess Rameshji, I've seen him very closely lately, and he is called the senior vice president, but I guess is one of the most senior persons in terms with his mental growth, uh, besides his physical, because I find him very mature, and I wish him all good luck in all his
Thank you.
endeavors. And with that, I would like to say that Ashish ji is so popular. I visited and have been and I've seen his center when he was awarded with a oration in Gujarat last year, and I had the pleasure to be there, and you visualize that moment which and the love which he has received from his the parents and the patients is what he is very popular and phenomenal. But only thing I wonder is he never grows old, because 2 decades back I saw him, he was as young as he is now. So he is a perennial young physician that I know of. And Sanjay Wazir is an extremely popular person in my beloved state Haryana, because he's the first DM, he's the first DM of Haryana. So you can see today they've gathered all stalwarts with this, and Dr. Naveen Jain so beautifully said, so humble, and there's one of the first persons I learned in South about his neonatology, and I'm looking forward to hearing the pearls of neonatology with a simple, humble statement. If I wouldn't have been a gastroenterologist, I would have given these three people a tough time, because I'm very fond of neonatology, and I probably would have been a neonatologist.
Thank you. Thank you.
So
What
nice.
is more?
Thank you, Neelam ma'am. I acknowledge the presence of Dr. Ruchira Gupta and my close friend, Dr. Sandeep Trivedi. Now, Dr. Guru Prasad, my VP colleague, please bless us, sir, being a guest of honor today, please.
Sir,
Yes,
thank you very much, Ramesh bhai, for giving me this opportunity. My pronouns to all seniors who are present over there. Good evening, Dr. Neelam ma'am and all others. I wish this program all the best. Because I want to be short, I'm completing this, right?
Thank you.
Thank you, sir.
Thank you.
thank you
sir.
so
Bye.
much, Guru sir. Over to
Okay, sir.
Nitin bhai.
I think now we can start. Dr. Ashish, please take over, discuss the pearls of neurology. Maybe as we discuss first some Indo babies problems and solution, and then as they are discharged, when they are followed up. Maybe you can restrict to level 2, up to level 2, maybe not too much of level 3, because many of the members who have joined may not be having a tertiary care in ICU. But of course, I leave the ground to you to discuss whatever you think is the best. Over to you.
Good evening, friends. At the onset, I'd like to thank Nitin sir, Ramesh bhai, and everyone who are sitting here, everyone whom I'm seeing here. The problem is that I'm squeezed between all stalwarts. In the front, Dr. Nitin bhai, whom I've been seeing for last 30 years, right from my days at Bombay Hinduja Hospital, Wadi Hospital, and I've seen him working hard for the pediatric hematology, then became president, and then vaccine on master, and beloved teacher, beloved speaker everywhere all over country. And what about Ramesh bhai? Very silent, very humble person. He's been doing so much for the IAP. I must say that in spite of all odds coming from a distant village, not village, but district place, he has been putting his mark on the national scenario, which is worth praising. Thank you very much for this invitation. And on the other side, I've got my friend Naveen and Sanjay. Again, what to tell about them? Big stalwarts. They have done enough in their field for years together, extensively practicing neonatology level 3, level 2, apart from being very good human being and very big academician. So it was nice to know, Sanjay, that you are first neonatologist from Haryana. And maybe same will be true for Naveen also from Trivandrum. He might be the first neonatologist. So years have passed since they cleared their neonatology and now they are in the with me at the moment. I noticed the presence of Dr. Neelam Mehan. Many thanks for your kind words. Yes, you were there when this oration was there, and was lucky to have you in the audience. And nice to know that you remember those moments. Dr. Ruchira, Dr. Sandeep, Dr. Alok, Dr. Guru Prasad, welcome on board today. The plan is to discuss about important part of the neonatology, and as Dr. Nitin sir said that we'll be restricting it to level 2. So that is what the message for the Naveen and Sanjay. But at the same time, we would be discussing what is evidence-based, what is recent, what is doable in Indian senior, which is most important part for the places that we work. I keep on saying everywhere that places where the books are written are not the places that we work. So we need to modify our practices according to our need and our place and our region. And based on that, we will start with this discussion. So when you talk about neonatology, obviously you can't forget about the fetus and delivery room. We'll not be discussing about the fetus a lot, about ultrasound, antenatal care and all that. But the most important part, and we have been seeing antenatal steroid being used right and left, and now the use of the steroid has increased like anything. Most of the mother who are going to deliver preterm baby, or at times even overused, I must say that, without preterm, but because it is a precious pregnancy, steroids have been used, that is fine. But then there are recent developments in usage of antisteroid. Steroid. So one important part would be that people have started prescribing or using it beyond 34 weeks, because initial recommendation was if the mother is supposed to deliver a preterm baby before completed 34 weeks of pregnancy, the steroid were to be used and is to be given, and then baby was to deliver. So Dr. Naveen, can you please throw some light that what is happening with late preterm steroids or early term steroids? I'm talking about 34 to 37 weeks.
Yeah, I'll first give the answer in one line that if you have a choice, please do not use it beyond 34 weeks. There are scientific bodies which do support its use, do recommend its use. So somebody, Sanjay or Ashish, might want me to give a divided opinion. Why is this question of not using? Is whenever we do a therapy, we have to balance benefits versus risk. The risk of the medication actually remains the same across all gestations. Steroid is a medicine which has potentials to retard growth and development. And it does cause harm to a 23 weeks pregnant fetus, 27 also, 32 also, 34 also, 36 also. Neurodevelopment is retarded. But when it comes to a baby of 27, 28 weeks, the risk of being born premature with an immature cardiorespiratory system is so high that mortality and development risk becomes this big. And therefore, the risk is only this much. But when you're talking of a 34, 35, 36 weeks pregnancy, then the risks are still there. Benefits are also very low. There has been sufficient evidence to the extent that many countries are giving out signages for parents which clearly read out that there may be some decrease in risk of transient tachypnea of newborn, minor respiratory distress, but there is an increased risk that your baby's brain development may not go well if you have been prescribed steroids beyond 34 weeks gestation. Please talk to your obstetrician. Is it important? So I would just leave with one message that the guideline which came more than 10 years back from British Society had predicted this happening. And they had written down that tomorrow an obstetrician should not use an antenatal steroid as an umbrella of defense and say that because I have given antenatal steroids, now we can deliver the baby at 34, 35, 36 weeks. In fact, all of us have heard parents angrily asking that steroid तो दे दिया था, अब क्यों डिस्ट्रेस हो रहा है? अब बच्चा सिक क्यों हो रहा है? स्टीरॉइड तो दे दिया था. अब स्टीरॉइड दे दिया था का मतलब ये थोड़ी कि मतलब 100 years की गारंटी ले ली है. I'll open up to Sanjay and back to Ashish also. So one line statement is beyond 34 weeks, the benefits are too low to be able to take the risk of giving antenatal steroids.
Yeah, I think Naveen, you probably synthesizes completely into one line that you should not be using. However, given the Indian scenario where I would probably just want to make a small adaptation to this. 37 to 38, there's no consensus. There is a consensus that they should not be used. The issue is 34 to 36 weeks, where most of our babies who come to your center or Rashi's center are the ones who come so late. They've been having a distress and they put on head box oxygen in a remote area. So, and once they reach there, they're in a bad pph and they've received so much of antibiotics that my so-called little mild distress that was there has really culminated into now high frequency and other scenarios. So my take on this is and how I practice M&M is so for people who are born in Gurgaon and the obstetrician, the message is clear. What you said, 34 weeks, do not give it because there are concerns about neuro handicaps in those babies. And if you want to use it, please discuss with the parents before the risks and benefits of using this particular thing. But somebody who's born at 50 to 100 kilometers from Gurgaon, where they do not have even a decent CPAP to do, I would rather want to obviate that risk of having that TTN and head box oxygen rather than, and that's an adaptation, purely a personal, kind of a, modification to the guidelines. But I mean, I just leave it at that.
And apart from the risk that you are saying about neurodevelopmental and brain injury and all those things, it has been actually proved that hyperglycemia and baby's hypoglycemia, maternal hyperglycemia, that creates problem for the babies, and that was one of the reason why British Society retracted their initial judgment or initial recommendation to use steroid 34, 35, 36 weeks. So at this stage, anti-steroid, right, Sanjay rightly says that it is to be given only on the selected basis for the periphery, may or may not be. But in general, one statement would be avoid anti-steroid beyond 34 weeks if possible. The problem is in the metro cities where it is being used as a sort of prophylactic, like this is IVF pregnancy and these are twins, so they are likely to deliver prematurely. And in that case, they started using steroid at the age of viability. That okay, if I'm saying saving 26 weeker, we'll give steroid to all 26 weeker mother because they're high risk. Is that a right approach, Sanjay?
Well, unfortunately, I understand. So I have failed to find that terminology in any obstetric or neonatal book, the so-called precious pregnancy. Like all pregnancies are precious, but somehow, like all obstetricians love their patients and they call them precious pregnancies. So pregnancies are kind of divided into then one that's inevitable birth, which is going to happen, and one which you're not sure about, like that they're going to happen. So, and just say for example 26 week baby with a little bit of a bleeding here and there, and then everybody says, okay, let's first give an antenatal steroid. Then most of them would not be delivering as like the statistics say, and eventually at like they have a spotting again at 28 weeks or 29 weeks, they again can end up giving repeated courses or like obviating the risk. And as Naveen said, there are risks associated with the antenatal steroids, but we also understand that there's a benefit of like giving an antenatal steroids to babies who are less than say 32 weeks, less than 34 weeks for sure, that the Indian guidelines also say. And unless there is a inevitable delivery which is likely to happen, and the way you would probably see if there is a cervical dilatation of or an established labor pains, you would probably then in that case give an antenatal steroids to reduce the respiratory morbidity and mortality. But for routine, because it's a precious pregnancy, is probably overkill and injudicious to my mind. But we all understand that we earn our earnings out of obstetrician, and someone whose wife is an obstetrician, I would, kind of put that statement very subtly.
The fact that reality is that in obstetrician file, if you said injection TT tick, then the vaccines, few vaccines to begin tick, steroids given tick. So that has become a routine, and I don't know, there is no authority in this country who can control this kind of situation. And one need to look into that. Probably the IAP or neonatology chapter need to talk to the obstetric colleague or obstetric society to at least, even if they are doing that, don't tick it there simply because this file goes to 100 junior doctors and they also start following that. So it is like a spread of wrong things at a wrong place. That is what is happening, and I don't know who is going to control that. Anyway, we'll move.
Ashish, on a very lighter note, the next time you speak something like to an obstetrician, this will be neonatologist Ashish Mehta cancelled. The new one.
So that is a different story. That is a different story. But anyway, let's move on to another cheaper intervention. And lot been said about Maxelf. Like when we started our neuro practice way back in first decade of this century, the steroid was something new and hardly 50-60% coverage was there. Over 2 decades now, the coverage will be something like 80% plus. But the fact is that recent article from my friend Cabra, article was something for something for some other for another topic. If you look at the table, methodology and all that, still in Mumbai city, coverage of the steroid is 68 to 70%. This is Mumbai city. Okay, so that's the reality. Another drug that Naveen would love to use that, and that is about anterior Maxelf. So can you throw some light on usage of Maxelf very briefly? Number one, to whom, when, to repeat or not, and what is benefit?
Yeah, Ashish bhai. The purpose of using Maxelf has been neuroprotection. And the genuine risk of major neurodisability would be possibly 30 weeks and below. At that gestation, we have probably gone beyond that line where just good neonatal care after birth cannot save you. You have already gone below a gestation where many concerns can still be there, whatever good you do. And therefore, proactive strategies to do neuroprotection will be useful. At gestations beyond 30 weeks, there are guidelines which talk 32, and in fact, even some are there which slightly beyond 32 also. The indication would be very selective, very contextual. But I think less than 30 weeks pregnancy, usage of magnesium sulfate should be there. And only what we need to remember that the old teaching we had of checking knee jerk is probably replaced by something more sophisticated where you can know the renal function of the mother and also know her urine output and magnesium levels. We have seen a few babies who have feed intolerance, hypotonia after birth, when mothers received magnesium sulfate and the serum magnesiums in the babies were quite high. And therefore, when you start magnesium sulfate thinking the baby will deliver and the baby doesn't deliver, or the mother is very sick, eclamptic mother with renal dysfunction, one has to be very careful about the doses going overboard. So these are the only two things I need to say. So below 30 weeks, the risk of disability becomes quite high. And I think there is genuine reason that we must use magnesium sulfate. Between gestation 30 and 32, guidelines differ across various bodies. But please do not give for long durations. Do not give doses without measuring if there is renal insufficiency in the mother.
Yeah, the guideline says that it is to be used almost 6 hours before probable delivery of a preterm baby below 32 weeks. And as you said, few of the guidelines about 30 weeks. And the dose stays at 4 gram over half an hour slowly IV, not intramuscularly. and then per hour 1 gram for next 6 hours. If baby is not delivering in 6 hours, stop it and wait for the next bout of preterm episode of threatened preterm labor. So that is where the maximum stands. Sanjay, do you want to add to this anything?
No, I think one would need to understand which is the mother which is, because most of the mothers who are admitted with preterm delivery again do not really qualify for a magnesium sulfate unless there is a cervical dilatation for more than 4 centimeter, or there is a preterm pre-lip rupture of membranes with contractions. Now this is important because like so many mothers receive, and then when she actually deliver, because the effect would wane off the moment you take off the the infusion going on, and she delivers after 2 days or 3 days, then you're anyways not repeating that course again. So unless you are very sure that you're probably delivering that mother because of like say absent diastolic flow or whatever reason that you're delivering, and you can delay it for 4 hours and then give an infusion over 3 to 4 hours to ensure that the neuroprotection stays, or the mother is in advanced stage where she's likely to deliver in next couple of hours for with a maybe 60-70% probability, yes, that's slight. But again, that she admitted with some labor pains and you start giving magnesium sulfate, and like by the time you 2 days have happened and then you can't repeat it, so that would defeat the whole purpose. So choosing that particular case would be of importance, and I agree to Naveen's recommendation that 30 weeks would be good enough for most of our centers, given that like facilities for maternal kind of monitoring is not great except for metro cities. Like in rural areas, I would stick to 30 weeks rather than 32 weeks.
Great. So these are two important things without which we can't move into the delivery room. At least mother need to receive this and then getting ready. Now we have heard a lot about the delivery room preparations, and people in our friends in the periphery also started taking good care of neonatal care corner, resuscitation corner. They all have now warmers. They have got at least warming devices, good oxygen supply, clean sheets, clean hands, neat cord clamping. Everything is happening, but the limitation now over a period of time, at least for last 2 decades, I must say that for last beginning of this century 2000, we realize that oxygen is to be used as a medicine and not to be used haphazardly. And now we all have heard the guideline for maintaining SpO2 levels right from the delivery room. As we know that 60 seconds, we are going to kick the SpO2 to 60 to 65. And by 10 minutes of birth, the SpO2 has to be between 85 to 95%. That we all know. And Naveen, do we have different guidelines for the preterm babies that to the delivery room, or the same guideline which are mentioned in the NRP for the term babies will imply over here?
When it comes to preterm babies, I think we will have to qualify, because most of our audience today would possibly be dealing with the better preterm babies, which we need to talk about.
Sure.
Maybe something like 33 weeks to 36 weeks. I would be casual in saying that you could club them virtually with the same term babies and start with room air resuscitation, because their respiratory distress rates RDS is not very high, given that even the husband gets antenatal steroids. So the risk is very low. Their RDS rates are low, and therefore you could treat them just like term babies. Try out with room air resuscitation first. But when it comes to the smallest babies, less than 30 weeks, who we give magnesium sulfate, who are at risk, they may not be okay with room air. They may be having a lung which is sick. They need both pressure, and they need to be treated with a blender where you would use at least lesser oxygen. I'm not sure whether we have all resolved as to whether it should be 30%, a little more than 30%. The research is still on, but surely we should have a blender and start at a lower FiO2. Look in responses in baby's tone, heartbeats, and if they're there, I think most of us become partly blind to those saturation numbers now. If the baby is having a good tone and good heart rate, then we are not looking for a pink preterm baby or a 90 saturation preterm baby anymore. So we would even be patient to wait for even something like 8 to 10 minutes, peacefully keep on doing everything else and not push the FiO2 higher. But of course, occasionally we get a very bad baby. 1 in 10 of these babies for severe RDS. You intubate them, and there you may have to use more FiO2. So we don't have a final answer on what would be the best FiO2 for extremely small and sick preterms. But beyond 33, 34 weeks, room air, at least for a start. And in smaller babies, first pressure. If tone and baby's activity and heart rate are good, don't be very finicky about saturation. Nobody looks at the chart and says how many minutes have you passed. Timer ही नहीं on करता कोई. So then how are you going to? But basically, if the baby's heart rate and tone are good, don't be in a rush to get the saturation to 90.
Yeah, but having said that, Sanjay, how many of us have the facility of blender in the delivery room? Even in the best places, right now in India, I say hardly 5 to 10% would have a facility of blender in the delivery room. And when we talk about the friends in the periphery, uh, oxygen availability is one thing. How will you think of having blender in the delivery room? Because blender means you're looking at the pressurized source for oxygen and air. Oxygen is all right, but pressurized air from where to get to blend that oxygen for the desired FiO2. What will you suggest to your Haryana friends or Haryana obstetrician?
Yeah, so the two things. One, like, we said that, about the comment, the 28 weeks and below, the failure to achieve 80% saturation by 5 minutes is associated with increased mortality. Like, so, I mean, a little caveat there that, you want to be getting at least more than 85% at 5 minutes in that subgroup of babies. But, coming back to the point that you're making, even in those facilities which have a blender, and most of the level 3 nurseries have blenders, but when it goes to the delivery room, there is one or the other reluctance on part of the either the staff or the doctor, or one or the other reason they would say, okay, we could not use blender in this because the baby was getting blue, or the ABC reasons. And because they, even if they blend with an oxygen at the time of delivery, when they have to transport the baby from the room into the NICU, again they come back to the 100% oxygen saturation again, because as you said, the compressed air is not available at most of the centers, even if they are level 2 level 3 kind of a nurseries. So I mean, that's a bigger challenge. We tried to discuss this with so many companies to give us like a compressed air cylinders, but somehow that, like, the no company is kind of commercially interested in providing that kind of a solution, at least for the transport from the delivery room into the NICU, largely because the number used by that would be much lesser. So that is one. And what we tend to use is, like, the transport ventilator, but I'm sure that again the facility is not available. So if you ask me, in reality, even in metro cities, not more than maybe 2 to 5% would actually get a complete blended oxygen right from delivery room into the NICU onto the ventilator.
Yeah, very well said. That the reality is that yes, the book says that the evidence. Yeah, Naveen, you want to add something?
At one point, I sincerely feel that with number of neonatologists being trained in larger numbers than was from the past, these trained neonatologists are forcing the organizations to buy blenders. So there may be 300 NICUs in India where neonatologists have reached and they're making them buy blenders. But वो डॉक्टर ही नहीं है वहाँ पे blend करने के लिए. So implementation of processes is equally important. Getting a blender there will not make blended oxygen reach the baby. There will have to be somebody who is equally skilled and trained for the delivery of such a baby. So if I miss a blender, I'll be okay, but I don't want to miss a trained doctor in there.
Yeah. So that's again very well said.
So sorry to interrupt, Ashish bhai. What about babies who are transported from a obstetric unit to a outside hospital? We are talking even struggling inside the hospital to the NICU, 5 kilometers away, 10 kilometers away, in crazy traffic of Ahmedabad or Bombay, takes 1 hour
That's
to reach. Where is the question of all this possible? Unless you have a very high-tech transport incubator and a team which can transport in the most ideal way.
that is where the limitation is of the whole thing. Evidence suggests that oxygen is not good for the babies. Evidence says that hyperoxia is not good. Evidence says underoxygen is not to be offered. Evidences are enough. But then when it comes to Indian reality, absolutely right. Even during transport, getting a blender into even my ambulance, I must say that is not available. What we personally do that we titrate the oxygen to make sure that baby should not get hyperoxic. So at least SQT is all the time on. And then my friend Murki has provided one MUTS CPAP, which monitors at least FiO2. There is a system by which you can monitor the FiO2 with CPAP. So that has been recently used in our ambulances, and that gives titrated FiO2, and on the other side SQT is monitored. But that is happening recently. But as you rightly said, in how many places in the whole country or even the metros, providing proper FiO2 or blended oxygen is a big question mark. And forget about the periphery, but in metro can't offer to deliver this kind of high tech thing. So that is the reality. Now let's talk about babies who are having distress in delivery room, and we know that keep the tube away. But why we need to keep tube away? What is the main goal behind that, Naveen? Why since that Colin Morley's trial, coin trial, every now and then people say about CPAP, non-invasive ventilation, keep the tube away, don't intubate. But then you rightly said that even in the preterm baby, there is a group of extreme preterm. I'm talking about babies, they are really fragile lung, fragile body system. Babies less than 28 weeks, they deserve different kind of treatment right from the word go. Then 20 to 32 weeker and 30 to 36 weeker. These are three different. They all are prematures, but the spectrum is little different. The care required in the delivery room during transport in the NICU is little different. The problem is that everyone is being treated with the same thing. Is that right approach, or we should have our different approach for the different groups?
Ashish, before we started the meeting, Ramesh sir and Nitin sir told us that 2000 people watched this program. And I'm going to use this opportunity to at least send one message across to 2000 friends. If you're going to invest this valuable evening into learning something, then it is on buying a TP's resuscitator. Maybe an ambu bag or what is a self-inflating bag is less expensive, but TPs has changed the way we are practicing for last 15 years. Previously, we would be trying to give the C and E hold, trying to bag a baby, inflate the lung, and invariably the distress used to be distressing to us. We would intubate the baby in labor room. Now that we are intubated, we'll as well give surfactant. And then when you come back, then you think, अब निकाल दिया तो फिर दोबारा intubate करना पड़ेगा, and they remain intubated for a long time. And there is no need to discuss that it would cause harm to the baby's lungs. It would cause risk of infections and future harm to the baby in every way, in the lung, in the brain, and pain and everything. And after we bought the TPS device, we thought, let's audit. In fact, the newer guideline which Praveen sir has just issued recently, they have called it as fixed pressure devices. That means you fix the pressure what you're going to give. That's how they classify it. So fixed pressure devices ensure that whatever PIP and PEEP you dial, it will give that. In fact, you may not even get a PIP. So if you just hold like this, वो कोई CNE की जरूरत ही नहीं है, ऐसे बस hold किया. A nurse, a new resident, a consultant who has stopped working for a long time, anybody can just come and hold the mask on the face. The lung inflates, pressure is delivered. 50% drop in intubation rate is what we found within 6 months of buying the device. 50% drop in surfactant use. 50% drop in ventilation. And no change in mortality, no change in bronchopulmonary or long-term lung injury. So you invest 1 lakh rupees. This is how it costs now. When we bought it long back, it was much cheaper to get a good TPS device. Anybody in the labor room sees distress, don't ask a question. Just apply the mask. You can dial the pressure before you go in. Rarely you would need to give even PIP. By the time the baby comes to the labor room, to an ICU, 80% of them won't have any distress at all. You don't have to intubate them. You don't have to give surfactant. So I think it will be an index of quality of delivery care in the labor room as to how many babies you're still intubating in the labor. So I'm not going to discuss 26, 25, 24 weekers because that's not what we're discussing today.
Yeah, but Naveen, you are rightly saying that problem is that we are trying to keep baby away. We are trying to use non-invasive way of inflate the lung. The problem is during transport. That is one, because once your baby is sick and distressed, let's say 32 weeker, 1.5 kg baby, steroid received, normal delivery, suddenly popped out without any reason and starts grunting in the labor room. That is scenario. And if you are there and you start begging, you are using TPs, resuscitator, and as you know, in your hospital, the labor room is your NICU is next to your labor room, so that is fine. Baby is transported with TPs in the NICU and fixed on the CPAP. That is one scenario. But then when you talk about the peripheries where the baby need to travel distance to reach to the right place, what will be your take for this kind of group where how to manage those babies? Even Sanjay can chip in for this kind of situation coming from the peripheries and settling into the NICU. How to settle them? How to transport them?
So very valid question, because like even the CPAP devices on the travel, on the transport, are like very fragile and inefficient, to say the least. In Indian scenario, most of the devices, they are not really the great quality, especially when we come to those the Indian versions that which are available and indigenous CPAP. So you really qualify the baby based on the sickness, and we all understand that pre-transport stabilization is an important factor to determine the long-term outcome when it comes to the stabilizing in NICU. If the child is getting transferred, say 32, and we are restricting ourselves to 32, 34 weeks babies, like largely, but a 32 or 34 weeks baby who coming from an outside with some kind of a distress, and say Downey score is like 4 and oxygen requirement is not high, I mean, you would probably continue with whatever CPAP machine or you have on the go. But if the child is already on a 50% FI2 and like a significant distress, I would rather say, okay, like a short kind of a ventilation for this baby may not be that harmful, rather than risking a pulmonary hypertension on arrival. So I'll say, okay, my resident is going, I'll say, please, like, if possible, give us a fact, and they are given intubation, get the child, assess in our NICU, and take out. Like, because it's a relatively 30 to 34 weeks babies that we're talking about here specifically. These are not the real candidates for a chronic lung disease where we need to see, but they are definite candidates for pulmonary hypertension and the complication and a pneumothorax and so many other aspects. So for a short duration, I may not be that averse to getting those babies on a ventilated transport and get back to extubating them as soon as possible in our unit, because that's a controlled situation.
Perfect. So, in all, what the message would be that for a borderline babies, better to you are all right keeping on the CPAP if you have got NICU next to the labor room. You do not want to keep the tube in. Just do not intubate at all. Keep on the CPAP, transport on CPAP, and rest of the things can happen in ICU depending on the baby's clinical condition. But those who are come the periphery, rather than staying on the CPAP and having apneas, distress worsening during transport, it is better to fix them before transporting, may intubate, give surfactant if possible. The retrieval team can do that, transport them and then fix them or extubate them as condition permits. So that is what the message would be, rather than sticking that not intubate, just keep on CPAP and transfer. So that is what I would like to bring to the everyone's notice. Now, once it is coming to the NICU, everyone would like to use surfactant these days, and obviously usage of surfactant, rightly or wrongly, has increased like anything. For small babies, we all agree that yes, we give surfactant, fix them. We know that lungs are bad, better to give early as possible. We know everything. Surfactant decreases the pneumothorax, decreases ventilation, decreases BPD. So many things are there. But for this borderline population, 32 week and 34 week, what would be the cutoff to give surfactant? Should all of them should receive surfactant, or they should be all right simply on NIV, sit tight and wait for the baby to improve? What is your take on this, Naveen?
2 hours. If you are unable to reduce the FiO2 to something like 24-25% and stay with 5 to 6 pressure, irrespective of gestation, I'm just saying, because you're treating the lung and not the gestation. But you're nearing 2 hours, you have done good care in the NICU, you're given adequate CPAP, distress has been taken away. Wait. Your FiO2 has come down, wait. But at the end of 2 hours, if baby still has distress, still has FiO2, this is one medicine where the benefits are very, very high if used correctly, and the risks are very, very low. So delaying beyond that would land up the baby getting a costlier therapy in any ICU in the country, whether it's public health or private. लोग कहते हैं public health में तो free है, free कुछ भी नहीं होता. Depends on who is paying, government or patient. But 1 day of intensive care is not less than 15 to 20,000 rupees today, and 1 dose of surfactant. So neither the cost justifies, the risk is very low, benefits are very high. So if you have reached that mark of 2 hours and the distress is more than requiring 6 PEEP, FiO2 more than 30%, I think it is criminal not to use surfactant.
Yeah. So yeah, Naveen, Sanjay.
Yeah, largely agree with that. Like, the only thing is probably the bigger babies, like sometimes you may just say if it is very early, 30% would be good enough, because we understand that the late benefit, late rescue, sorry, is not that great as an early rescue. But if you have already like more than 2 hours, for example, the baby coming from outside, and it's just like 35% or 37%, I would see which direction it is following. If it is like stable, I would probably just avoid kind of putting in a tube, and it also depends upon which facility you are. For example, if you have a high infection rates after putting in, and you do not have, it's middle of the night and people don't want to extubate, I'd rather say okay, stick on and not do it. But the primarily, if it is crossing 40%, for sure there is no discussion. The choice is between 30 to 40% in a child who is already 2 hours late, because now it qualifies for a late rescue. In that scenario, maybe 30, anywhere between 30 to 40% stable FiO2, just hold on. Like improving, do not do it. Worsening, do that. So criteria for less than 2 hours, I mean, maybe then 30% is something that what we follow.
Or we say that, okay, bigger the baby, you can wait little bit bigger, in the sense more than 1.2, 1.4 kg near, you may wait for 40% to reach and then you decide. But the smaller babies, which we are not discussing here, less than 28 week, or anything less than 30%, anything more than 30%, even 25%, give it and stabilize the baby, or let the lung improve. So that is one part. Another issue is that evidence is enough for the LISA, MIST, so many things are there in the horizon. And recently I had been to medical college, and then see the question, the first question that was asking to me was, sir, do you LISA karte ho aap? मैंने बोला LISA, yes, karte ho. Then I asked them that, why do you want to do that? Believe me, they were aware of the number with that, the percentage by which the BPD can be decreased LISA, decreased by LISA. That was there. But do you agree that we need to venture into LISA? This country, or this justice rate that we are treating, or the kind of preterm babies that we are treating, do we need LISA? Naveen or Sanjay?
So, like, as you said, our NICUs, whether like any NICU, government, private, anyone, will largely talking about babies who are more than 28, 29, 30 weeks. And we would put our pictures in newspapers and Facebook ads saying that we saved 28 weeks babies, but we would have probably done it maybe once in a month, even once in 2 months. So so LISA is really relevant for those babies rather than to like. Now there are two problems with LISA that I see. One, because the numbers are so low, that your expertise is so low, that you will probably create a mess out of doing a procedure once in 2 months, once in 3 months. If you are like, so do consistently what you probably can do all the time. That's the message. So changing protocols for every single baby, every single preterm may not be the best way to keep your sanity in your unit. Second problem with the LISA is that, like, it's a technique which we think is going to reduce PPD, But we forget that BPD is caused by so many other factors. From an oxygen we just talked about, from nutrition we never bother about, from like avoiding mechanical ventilation infections to host of other factors. So like just Lisa is not the fact. And third is that because like we have been trained in residency, because we never had simulators with like कि भाई ये baby आया है इसको intubate कर दो इसी पे सीख जाओगे. And we realized that the expertise to do kind of like a right kind of a procedure comes only after you've done 100 such procedures on a simulator or some kind of a and 100 such babies. But what happens is every new like any gadget, most of the people are fascinated with using that. I use Lisa in my unit, so even if I've done one baby, I'll start doing and experimenting without knowing even the pitfalls. So when I was in Guwahati recently talking about, so the company people wanted us to do, because that's their kind of benefit, to talk about Lisa. And you see, they're not have heard about a video laryngoscope. None of them could even hold a laryngoscope correctly, like the trainees, and they were come to learn Lisa. And now this is where my problem is. We should adopt technology, but in a graded fashion. So for me, as of now, India should be away from Lisa, at least for some length of time, barring few academic institutions.
Naveen?
We don't practice Lisa, and my residents are waiting for me to die so that they will use new technology. They think he has gone old and ये बूढ़ा क्यों नहीं नई चीजें लेता, सारी दुनिया आसपास लिसा कर रही है और ये करने नहीं देता बूढ़ा, ऐसे बोलते हैं.
Yeah, so that is
But
what the message is. You're right. Yeah.
and second point is, any therapy which says they will reduce BPD by 50% is just marketing. Lung cannot grow just by giving surfactant this way or this way. जो प्रीमेच्योर लंग है वो तो ना स्टेरॉइड से ठीक होगा, ना ऑक्सीजन कम ज़्यादा करने से ठीक होगा, ना सर्फैक्टेंट से ठीक होगा. वो 8 या 9 महीने हफ्ते में ही ठीक होगा. तो if somebody says 50% reduction, then send that article for journal club review.
So very well said. The preterm lung will not get better with steroids, surfactant, or anything or anything, or CPAP. But one thing with which the lung will improve is weight gain, nutrition, and time. So that brings the question to the nutrition part. I mean, which baby, because we all learn that do not harm. That is most important part. And we know that the if you take about preterm mortality because of the premature itself, the second biggest cause of death or the morbidity is sepsis. Sepsis-related all kind of problems that we face. And we all know that the best way to avoid sepsis is hand washing, clean disposables, clean procedures, everything. But when it comes to do not harm, one thing is most important to me is avoid putting intravenous lines. Not about central, even peripheral, simple cannulas. So when a resident in my unit is putting cannula, is always tell them, ask yourself, do I need to put this or insert this Vigo or not? Having said that, that means I'm allowing baby to go on full feeds or partial feeds or early enteral nutrition kind of situation. So which baby will qualify for full feeds in your unit or your thinking, Naveen and Sanjay? Which baby will not put IV lines?
Ashish, I'll think that our seminar has just started. Because despite of Nitin Shah sir and telling Ramesh sir telling that please remember that this meeting is for a larger audience, we were just flying a little high and our notice now started coming to real neonatology.
Okay.
So I will take the question one step behind from where you started and just share some passionate things that we need to do. Every pediatrician who is here, please ask your labor room to stock a breast pump. और टर्म बेबी के लिए तो कह रहे MBFH करो, लेकिन जो प्रीटर्म बेबी है उसको 2-2 दिन तक प्रीटर्म ब्रेस्ट मिल नहीं मिलता. 1 घंटे में टर्म बेबी को मिलना चाहिए, तो प्रीटर्म बेबी को कब मिलेगा? But we found in our own quality measure that the problem was jab tak preterm mother gets an information that she needs to pump breast milk, then somebody has to buy the breast pump from somewhere, then somebody has to teach her how to use it. By the time we talk about what's colostrum mouth paint, its benefits, and breast milk coming, then you are into questions ki formula milk दें कि parental nutrition दें कि donor milk दें. But the better solution is number one, the breast milk pump should be there in the labor room and available to the mother after she is stabilized. Number two, after the resident has taken his gloves off after enjoying putting tubes and into the baby's glottis and into the umbilicus, the next he takes a photograph and goes to the mother and says, look, your baby is safe with us. We want him to continue being like in utero, continue the same growth for this, everything. And that magic only you are having. I only have an ICU. I want you to give breast milk. Start pumping now, but you will not get breast milk in enough amount for next 2-3 days. But don't get disappointed. Third day you will be giving magic to us. So I leave the rest of the questions to Ajay, Sanjay, because there's a lot to be said on this. You asked many questions about who will be on full feed, but this is a practical pointer I want everyone to share and use. Please have breast pump in the labor room to be available to a mother who has pumped. If you can't afford a breast pump, then manual pumping to be taught. But pumping of milk has to be start as soon as mother is off the labor cot for a preterm baby. And second, the mother should be reassured by showing a photograph and video your baby is okay. Tell her you will get breast milk slowly, but keep doing it every 4 hours so that by second and third day we can sit only on mother's own milk. Rest is from Sanjay.
Yeah,
Sanjay,
yeah. So we
the question is that in which baby you will not put intravenous line? Preterm, term, everyone, you can include everyone, but question is how to avoid intravenous lines.
So, see, one clarity is very sure that there's somebody who's more than 32 weeks and 1500 grams. All of us had a significant experience that most of these babies do well and can be on complete enteral feeds. Even if means like you do not have breast milk, you can still start with a formula rather than putting in an IV lines. That's like, there's no kind of ambiguity in that particular area. Now the ambiguity arises somewhere between 30 to 32 weeks, and somewhere between 1 kilo to 1.5 kilo babies. In babies who are otherwise well, who are not showing any abdominal distension, did not require resuscitation at birth or significant hypoxia, and do not have a hemodynamic compromise as of now. Because if they have shock and other things, obviously those babies again cannot be on the thing. Now in that scenario, what we tend to do is, like, we understand there are trials from India which say, okay, you do it in this scenario, and there was recently one unpublished trial, in fact a published trial from Gulbarga, where they said 25% of such babies had feed intolerance. They did it. So what we tend to do at our units, 31 weeks and above and 1300 grams, you put them on a full feed, provided they meet all this. I mean, if you are still underconfident, at least take a vow that 32 weeks and 1500 grams, there's no need for giving this, and you can keep decreasing that kind of a thing. So there's no one single gestation that we would tell, okay, this is something which is a magic number, and after this you will not have NEC and you will not have, but you need to see that you would have one number at least, that where most of us have had an experience, 32 and 1500 grams. Less than that, sicker babies, keep decreasing your gestation by one and see the results. If you see, okay, your 31 weeks and 1300 grams are doing fine, maybe next week you could do it 30 weeks and 1100 grams, and so every unit would develop their own culture. But I mean, that's my take on that particular.
Yeah, so ultimately the message is that we would like to avoid intravenous lines in most of the babies if possible, and as rightly said, that keep on decreasing the gestation by one and try to see, because everyone will be in learning curve. Most important part is whether baby is ventilated or not ventilator. Even with the ventilator, baby can be on full feeds. Ventilator does not mean that you put them on IV lines or umbilical lines and start IV fluids. So they can be fed. The problem is that once those who are starting IV fluids, maybe half and half, or even let's say go the full feeds, little of distension here and there, little bit of aspirates here and there, the feeds are being held or the stop. So how would you manage this kind of situation about the aspirates, number one, and number two, tolerance. The word tolerance means, and it is subjective. The I find that babies are looking all right, and Naveen finds the baby is not looking all right as far as distension part is concerned. So how would you titrate the situation where you say that nothing doing, baby will I will continue with the fits? Naveen.
We have not been able to change this word tolerate. Our unit resident says baby is tolerating milk. I said, how can we tolerate? You should be enjoying milk. There's nothing bad about milk actually. So this word intolerance, if a baby is non-sick, that means he is neurologically intact, moving well, perfused well. We would just continue feeding without measuring any aspirate at all. We do not aspirate. I think it is tearing the mucosa. And we don't do abdominal girth also, because actually when I do my abdominal girth, then I suck my abdomen inside like this so that it will look 2 centimeter lesser. So जिसको फीड बंद करना होता है वो थोड़ा लूज पकड़ते हैं, जिसको चलाना होता है वो टाइट पकड़ते हैं. Abdominal girth and aspirates are of no value. If a baby is non-sick, please continue feeding.
But then Sanjay's concern is about NEC. So how to balance this kind of situation that don't use the word of intolerance, but at the same time I'm concerned about NEC. Sanjay, how will you take that part?
See, again, NEC is a disease which is primarily limited to less than 32 weeks predominantly. Now, 32 and 34 weeks, whenever you give, as Naveen was saying, you give them feeds. So some of them would show aspirate, some of them, but if the child is looking well and you are a sound clinician, then there is no need for you to rely on your nurses to tell you whether the gastric aspirate or umbilical, gastric abdominal girth or whatever you need to do it. So you had, and this would happen. See, if I probably sometimes take and I have a bloating after dinner. Do I skip a breakfast next day morning? No, I would still eat up and till I have a persistent problem, I show up. So similarly, because you had one or gastric aspirate here and there, and since you had like one distension, is unlikely to be NEC. Now, most of these feeding intolerances happen on day 1, day 2, when you're starting, and trust me, that is not where, when the NEC starts. NEC starts in a relatively hypoxic environment, whether at time of delivery or after delivery, and in a sicker child where the circulation is impaired, maybe then you need to be worried. So then less than 30 weeks, probably you need to be going a little slower. Thing, and one odd gastric aspirate here and there, or if you have done for whatever reason in a relatively well looking child, you can blindfold yourself and keep going. Maybe you want to skip one feed for the sanity of the ward around you, and then next because it will usually settle by one word, but unnecessarily prolongs it further. So I would probably say that you would want to be a little careful in stopping feeds in more than 32 weeks. Less than 32 weeks, you probably can be a little cautious, but not certainly overcautious. Less than 28 weeks, you probably may want to take it more seriously rather than looking at.
At the same time, I want to add on to this whole discussion about the way the feeds are being prepared and the way the feeds are being delivered. Because as we know that कोई भी खुमचे पे जाके खाते हैं तो डायरिया होने के chances होते. The way the feeds are being prepared by our nursing staff or our co-staff is also to be observed and supervised. They need to wash hands. They need to use that plastic gloves, then proper vatis, katoris, the way that has been carried from the station to the baby, and the way that is to be delivered. And after finishing the thing, again the vessels are cleaned. So this whole process, if not been put right, then again there are chances of the so-called NEC, so-called sepsis, because it is sort of, yeah, Naveen?
One practical point is, for billing purposes, many times units have one formula tin for each baby, but that is totally counterproductive. If you buy one formula tin, if you have to use formula for the whole unit, it will run out in 2 days, and the risk of formula associated infections become very low. So try to finish the tin as early as possible after you open it. I don't know how you will do the billing process, but if you ask one tin for one baby to last for 1 month, and there is a guarantee that you will have infection associated with the formula.
Yeah, so that's what the message is, that when you're preparing the feeds, it is very important to observe how it is been prepared, how it has been delivered to these little babies. Having said that, again you are opening the another discussion, Naveen, here, formula versus mother's milk versus donor milk. And we have mothers who are exclusively expressing and giving to the babies, but then there are cases where this luxury of mother's milk is not available. So which options there, number one, and there are few things in the market commercially being sold, whether to encourage, whether to discourage, with the label that is donors human milk. Where do we stand here, Naveen? Or even Sanjay can take it.
Personal viewpoint, mother's milk, everyone will agree, there's no doubt about it. I feel donor's milk is drama milk. It has no benefit left after you have pasteurized it completely. Biological properties are dominantly lost. You may do some mice study by throwing something and showing एक neutrophil बचा हुआ था उसमें, एक lysozyme बचा हुआ था, एक vitamin E बचा हुआ था. But if you have done the same process like you did with the formula milk, वहाँ 50 गाय से निकाला, यहाँ 50 मम्मी से निकाला, फिर उसको लिया, फिर पैस्चराइज किया, फिर टिन में पैक किया, फिर बेचा, तो वो उतना ही खराब निकलेगा जितना फॉर्मूला मिल्क निकलेगा, और उतना ही पैस्चराइज करके सारे गुण चले गए उसके. So science also has failed to prove any benefit of donor human milk over formula milk, not even in feed intolerance, NEC, growth, किसी में वो mother milk रहा ही नहीं. So, but this is personal viewpoint. Yeah, our unit does use donor milk occasionally when they are dealing with very, very tiny babies like 23, 24 weeks babies. डर लगता है सबको फॉर्मूला से, तो हम भी कभी कभी डोनर मिल्क यूज करते हैं, डर के यूज करते हैं. But like we all have been discussing, this may be applicable to 23, 24 weekers, 500, 600 grammars. But when you're dealing with 28, 29 weekers, I really don't see whether we should be sold out.
So sorry to intervene. Are you
Yeah.
trying to say, Naveen, that the human milk banks are all superfluous?
Human milk banks are different from the donor human milk, which I said, which are collecting, pasteurizing, packing,
So
selling
even
like
even in the
formula milk.
yeah, but even in the human milk bank, they will pasteurize before storing it, isn't it?
Lot of properties are lost. Lot of properties are lost.
No,
Sir.
no. I'm asking you. I may be ignorant, but a human milk bank, not the professionally available human milk, but one which is stored voluntarily, they'd have to pasteurize, right, to store it, or no?
Yes.
I heard in the beginning that you prefer to say call a spade, and therefore I will make a suggestion that I am not allowed to do it, but the old traditional unpasteurized shared human milk coming from a mother who has been screened is gold, but we are just copying Western world and trying to say CMV आ जाएगा, तो उसको उबाल के सारी प्रॉपर्टी निकाल देते हैं उसकी.
Yeah, but having said that, I mean, of course, we are on the right forum at the moment, but we should not be making the statement that donor milk is. Of
Yeah.
course, you might be right in saying at your level, but I must say that because so the buzzword is human milk bank, and it is where the milk has been pasteurized and been given to the needy babies or needy patients. In that case, at this stage, we should not be saying that it is of no use or it lost its property, blah blah blah. I would add on to that, yes, if mother's milk is not available, second one is the mother from the family, because they would be knowing the family, but like Datri Mata, that is what we can say, but they should be coming from the same family, and parents need to know the risk of using that milk without pasteurization. If that is acceptable to them, we'll do that. But if it's not there for babies like 26, 27, 8 weeker, rather than using formula, my suggestion would be to go for donor milk, which is coming from the right source and rightly been processed and rightly been stored and then given with the right process. What is your take on Sanjay?
No, so and a subsidiary question that the human milk bank, which are usually in the public hospitals, the human milk which is donated is voluntary, is free. Whereas the mother, if she has to be given formula feed, will have to buy that too. And so that adds to the cost. So, I mean, I understand the values might be lost, but like, even in a formula, the values are lost. But at least the human milk bank will give the milk free.
Yeah.
So,
Sanjay?
like, as you put it, Ashish, like we understand that once the pasteurization happens, there will be some loss of biological value, but then there is some evidence to suggest that, like, the donor milk would still reduce the incidence of like NEC to some extent, to like, and one of the other benefits which practically we had was that when we shifted, we decided that we're going to have only 100% human milk based NICU. And for 1 year, for almost 2 years, sorry, we had no baby who was given anything other than the breast milk, whether it was donor or or the baby from any less than 1500 grams. I'm talking about any baby who was like less than 1500 grams. Not even one single baby was given any kind of milk except for the mother's milk, whether it was donor or whether it is, and that helped the whole unit to get sensitized towards getting the breast milk, as soon as possible. That was a wonderful change. Till the time this like controversy about the donor milk happened, we all know about the product that we say now. I mean, I urge upon IIP to take it seriously, because when we talk of public health milk banks, they, like, we have say, two of them in Delhi, but they don't give it to other people. They say we use it for our babies, so they claim propriety over this use, whereas my babies who were getting a breast milk of whether they are or someone, even if they now can pay, they just can't get the benefit, and they have to struggle to get the formula milk from one of the other sources, like whichever, which we all understand, and we learned our neonatology and NEC from the formula milk, and we were going towards donor milk. Having understood that kind of a controversy, it's also important to understand whether the ethics of that company, like that we see, is what we are discussing, or the safety of our children that we are discussing. So this is something which again is a very semantic debate that we need to be.
Yeah. So once that is
So,
fine.
Ashish, sorry, there is one question on this. You're discussing NEC and feeding. Dr. Samir is on, of course, on the Zoom platform, and he wants to know a view of the probiotic or the prebiotic and NEC. Does it do good or harm?
Uh, so this is like
So, and before you answer, so Ashish, we are running out of time, so we have another 15-20 minutes, but that doesn't matter. You continue the same pace. We will
Yeah.
have part two of the same with the same faculty next month. So no issues. Whatever issues are still remaining on your question, we will continue the part two. So absolutely don't be in a hurry to discuss just because the time is another 15 minutes. No problem. Yeah.
Sure.
Sorry. Yeah, Dr. Sanjay. Prebiotic, probiotic in pre terms, good or bad?
See, there's nothing like a good or bad, I will tell you, but we need to understand, like when we hear, the common cold, we read in Nelson, we say, okay, supportive treatment is only required. We end up giving medicines. The diarrhea, we all understand that we need to have like a supportive management. We need to, we still end up giving probiotics, prebiotics, so many other things. Now, with that, NEC is a multifactorial disease, and adding probiotic or prebiotic does not change Indian NEC. Let me be very, I'm pretty sure about like Indian NEC, because Indian is more about like hypoxic babies, is more about like sepsis related issues. So I mean, and it takes the focus away. When I talk to so many pediatricians in the periphery also, they say, oh, we have added a probiotic, he was having feed intolerance. Like, so what is the milk? Like, formula milk, how is the concentration? I do not know. What is the sepsis rate? Very high. So then you're bound to have NEC, and you're going to have a very kind of a flimsy, dissatisfaction, that you've probably done enough to obviate NEC. You probably need to go back and say, I'm not using any probiotics, and now how can I prevent NEC in my baby?
Yeah, but I mean, there are several issues with the probiotic itself. The preparation, number one, the concentration available in the sachet available in the market, the required dose. Again, there's a lot of controversy about the different strains and different doses, and the way it has been prepared. because there are issues where the probiotics will be used and baby develops late sepsis. Then the argument is that this is a better sepsis than the the sepsis which you get from the nursery. So there are a lot of if and buts. But having said that, over a period of time, this is like that for that but any science, new thing comes and then gradually there are evidence against it, and then it disappears or it disappears. Same things probably happened in the probiotic when it started somewhere in last decade, 10 years back. People were right and left using probiotic, particularly came from the Australia. Our friend Deshmukh and Patole sir, they were very much into this NEC and probiotic. But then gradually, once the other units started using that, people realized that if your unit NEC rate is very high, that to surgical NEC, then it helps, but not for other regular NECs. And then when it comes to India, probably we do not have the right product, which is actually being scientifically studied. It is like steroids. The right product is not there in Indian market. So in that case, rightly said that probiotic and Indian NEC probably has not changed the course.
So which means the bottom line is not to use in general.
Yes, in general, not
Yes.
to use that.
Okay,
And
please
that too-
continue.
Yeah, please. Okay. So then it comes to the discussion about this breast milk part further. Now we talk about some term babies who are coming to the OPDs. And the anxious mother, first time mother, very young mother, isolated families, no family support. And there is always concern about they would like to feed them baby with exclusive breast milk. That is what that is what is been told. That is what the Google says. But then let's take about a baby who is coming to Sanjay's OPD on day 3 of life, and baby has lost, let's say, 9.7% of the birth weight, and that has been calculated by the parents that sir, my bacha 3.5 kilo tha aur aaj 9.5% exactly has decreased day 3 of life. Sanjay, what is your take on this now?
Now, like, we need to understand this is a very, very pertinent question, and I think every one of us would face this in next 1 month of our OPD. So it's like, so for the neonates, first few days we know there is a weight loss, and weight loss of around 2 to 3% per day is acceptable, and weight loss of up to 10% in the first week is within the so-called physiological range, particularly for the breastfed infants. However, like, a weight loss of 9.5%, you said, no?
Yeah, 9.75.
Sorry?
9.75%.
So you're just like hanging on the balance itself. So so weight loss of 9.5 on day 3 is closer to the upper threshold, and it warrants like close monitoring. So I would not say like should we do A or should we be B, which means that I continue with breastfeeding or should I continue with the formula. But it is important to ensure, because we all want to protect breastfeeding, and we need to see latching. Is the child latching well, feeding frequently at least 8 to 12 times per day? And then this is, we monitor this baby. Supplementation with formula or an express milk should be considered only if the child is not feeding effectively, there is an evidence of dehydration, for example decreased urination, lethargy, or in due course when you are
और
monitoring.
9.75% तो लेस हो गया तो 10% तो माइल्ड डिहाइड्रेशन हो जाता है सर.
नहीं सर, मैं वही कह रहा हूँ कि अगर देखो 9.7% हम एक नंबर को देख के चलेंगे तो हम वो डिसीजन है, बट क्लिनिक्स is not, clinician's job is to look at whether that number is relevant for that particular baby or not relevant for that baby. Now if the child is latching when just because he suffered like some weight loss on day 2 itself, and now he started to make all the efforts to drink milk effectively, I would introduce a formula. That would be wrong on my part. I would rather say, okay, so I'll do a latch score to see. I would probably have spent time and say, okay, if I do not have time, at least the lactation one can see whether the feeding well. If the child is feeding well now, he was not doing it on day 1, day 2. What is the hurry? Like, I can weigh him after 12 hours again. So what is but to interrupt a process of breastfeeding in a child who's exclusively breastfed because of a doctor is unpardonable. So as I said, supplementation should be considered if I feel okay, the latch is not proper, there is likelihood of the child going into this thing. And then if you see if this child is still continues to lose weight, not feeding well, supplementation for sure. We do not want breastfeeding related hyponatremia and dehydration related issues. But again, you need to be cautious. There's no one answer that 10, if it was 10%, should I go for supplementation? I'll still say, watch the baby. Every child is different.
My mother-in-law want me to start formula, sir. What shall I do?
So so one thing I've realized that if you want to tame one female in the whole family, it has to be the mother-in-law. It may not really so you could probably keep giving any gyan to the mother about breastfeeding. She knows it more than me. But if it's one woman who needs to be convinced about and we need to see how do we probably convince the mother. So many of us, we tend to, as doctors, tend to go, it's like nahi nahi, aisa nahi hota hai. And it's like the grandmother says ki, you are telling me, you are younger than me, and you're telling me ye nahi hota aisa. She says, okay, this doctor ko kuch nahi aata. She goes to the family again, well, let's change the doctor. So one thing that we need to understand is that we do not need to be at what head on with the family, and especially the elders in the family. That's you would lose the patient's trust, and you would probably not do the service. So important that you probably would want to talk to the mother. Why do you think, grandmother, why do you think that the baby is not having, what is the thing? And if she still feels unconcerned, I would say, okay, can we do this thing? Can we take the decision tomorrow? And say, okay, if you will, let's check the weight, let's do the urine, but not be in a hurry to argue, say, okay, no, 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 ye theek hai. The way we do it in a busy OPD. So we antagonize the grandmother and we lose, so you may try anything. BC21 is being used.
So
You may
counseling of mother-in-law is important than mothers. Am I right?
in Indian scenario, for sure, even the God could not save, so he had to go and convince the mother-in-law first before. So
Naveen,
But I think why not tell the mother? See, I mean, after all, they very quietly said that she look, this is your baby, not your mother-in-law's, your mother-in-law's baby. Okay, some decision you will have to take, not now, but even in future for many other things. So maybe use the husband as a leverage, because the son we can tell very bluntly to the mother than the daughter-in-law to the mother-in-law. So I mean, something like that, jugaad, and buy time, as Dr.
But
Sanjay
but
said.
but problem is see, every scenario is different. Say North India, mein,
Hmm.
where I practice, like Rajasthan, Haryana, the mother-in-laws dominate, like hell.
Yes,
So
yes.
this is maybe the scenario is down different in South or maybe in West, but here like Punjab, Haryana, and Rajasthan, they are the supreme, in the whole family. So convincing them should be part of the whole strategy about protecting the breastfeeding.
Naveen,
So one point I will add on this is that please make sure that you have a checklist of mother, breast, and baby factors before you get cynical. Baby factors is if this is a slightly preterm baby, 36, 35 weeks, slightly low birth weight baby, already showing what you said, weight loss, dehydration. There are breast factors where there are real issues with breastfeeding, or mother factors. She has a previous IUD, neonatal death, advanced age, medical illnesses. So these should be kept out of the ambit of what we call as MBFHI. In all other scenarios, please go with what Sanjay said, that you must push as hard. And today, most mothers have the benefit of having Googled enough, and you don't have to tell them the benefits of breast milk. Many of them are really wanting to do it, to the extent that sometimes they get neurotic if they're not able to give enough breast milk. So, but have a checklist of medical factors, making sure that you are not placing a at-risk baby or mother into a grind of MBFHI.
Ashish?
I will just add 2 points that sometimes we over zeal, in our zeal manner, tell the mother about benefit and almost making her feeling guilty if she has to start top milk. I think that we should avoid, because that puts more pressure on the mother than probably what she would do otherwise. And I distinctly know one lady, she would fight. She fight. She put a very bad remark on my Google saying that this doctor is of which ages he's talking about. feeding babies and mother milk and the disadvantage of bottle and all that. I mean, she put on the. I was very happy because I was telling the truth. But some mothers may very get offended that okay, who are you to tell me? I will do what I want. But then you have to guide them the proper top feeding. What I mean is.
Now, Ashish bhai,
Yeah.
in last few minutes, we can take up this 2-3 questions. One is by Dr. Sandeep Trivedi that avoid IV line cutoff any gestational age. But I think as we discussed, 32 weeks, I think.
Yeah, basically, baby, as a rule, any baby more than 32 and anything more than 1.5, I'll say 1.4, will not get IV to begin with.
Correct.
Correct.
Provided the gut flows and everything is fine, and most of the babies at this stage would be all right.
Yeah.
Right.
Problem is that which milk are you going to give? Ideally would be mother's milk, if not donor's milk, if not formula. Second thing, anything less than that, maybe 31 weeker, then it's a learning curve. So if your unit is started with 32, fine, go to 31, 31, 5, 30. Because recently published Sushma's trial from Lady Harding, she showed that even the smallest baby less than 20, 30 weeker, she started with the full feeds and there was success.
Ashish bhai, just one point
Yeah.
there.
Yeah.
Our babies are not reading that article. They refuse to.
You are right, perfectly.
Yeah. And second question, Ashish bhai, any tips for, again from Sandeep Trivedi, any tips for preventing pulmonary hemorrhage in preterm ELBW?
It goes by the etiology, Sandeep, because pulmonary hemorrhage is multifactor etiology. From the sepsis and DIC, very bad PDA, very bad pneumonias, and post surfactant. These are main causes of the pulmonary hemorrhage in our Indian setups. So you can't. Prevention is like you give vitamin K, maintain surfactant right in time, provided proper pressures and all that, and close the duct depending on the echo or the depending on unit policy. Apart from this, if the pulmonary hemorrhage is happening, it will go by the etiology. The outcome or the treatment will go by the etiology. Naveen or Sanjay can add on to that.
No, I agree. Like, very small babies, it will be a PDA, which is mostly the responsible factor. But relatively bigger baby, it will be either sepsis or sepsis-related coagulopathy, or sometimes inadequate pressure, like, which will be responsible. So, using a right kind of a management strategy as well as ventilation and avoiding infection for bigger babies, and of course, looking at a PDA in a very small babies less than 28 weeks would be the way to look at preventing the pulmonary hemorrhage.
Yes,
Ashish
Sandeep. Sandeep
Ashish
wants
bhai,
to
you
say
may take.
something. Well,
Yeah,
Sandeep wants to say
yes,
something.
sir, but patient is absolutely fine. No distress and no septic by investigation. In spite of that, the some LBW patient having preterm having pulmonary hemorrhage. In last month, I got 3 patient. Absolutely fine, no distress, no septic sign. Then they went into the pulmonary hemorrhage, and I can't save these patients, sir. Given 2
Sandeep
to
sir,
3 BTs and plasma also given to that patient, but not survive, sir.
Sandeep sir, I had just going to say the same point which you were going to say, that if your unit is getting slightly larger babies, let's say more than 30 weeks with pulmonary hemorrhage, or the events are common, then there may be to look at from labor room to NICU thermoregulation, fluid, because if these things are in control most of the time, pulmonary hemorrhage gets restricted to those 25, 26 weekers only.
Correct.
And so the strategies for prevention are actually a very valid question when you asked if you're seeing pulmonary hemorrhage more than once in a few months, and if you're seeing them in bigger babies. Then some things which we don't pay very fine-tuning attention to, thermoregulation from labor room onwards till here, at every point of time, and also trying to make sure fluid management is good. Otherwise, these bigger babies, of course, sporadically once in a while, it may be something unrelated, but this is what I have to see. This is what my feeling.
And at the end of the day, like ultimately the treatment would be intubate, stabilize, paralyze them, make sure that their ventilation is being managed well, oxygenation, blood gases, nutrition, asepsis, vitamin K, coagulopathy. Once you put all this right, they all improve maybe after 3-4 days. But these are bigger babies. Smaller babies generally pulmonary hemorrhages, PDA and DIC, then brain, IVH, and all this will add on to that. But bigger babies, pulmonary hemorrhage generally outcome is not bad.
Weight is approximate, sir, 1.1 kg, 1.2 kg, or
Dr. Sandeep, I just want to ask, say, were they extremely IVGR babies? Because chronic hypoxia does lead to idiopathic pulmonary hemorrhage. That's the reason I was asking this.
Okay. All are preterm, sir. Approximate 1 to 1.1 kg is there.
No,
That
I
means-
mean,
That means they were below 32 weeks generally, right?
Yes. Yes.
Okay. I think we'll have to wind up here because we have almost spent 1.5 hours, and I'm sure there are still more topics to be discussed, especially the ROP follow-up, then BPD follow-up, NICU graduates, especially very preterm, the care in the first few months, what growth charts to use. Do you immunize them in the unit or outside the unit, at what age, and so on and so forth, which itself will take another session. I think we will continue with the neonatology, Pulse in Neonatology part 2 next month. It is usually on the third Friday of every month. This time is an aberration, fourth Friday, because last Friday there was some issue. So if Dr. Sanjay and Dr. Naveen, if you can block your date for the third Friday of June, we'll be very happy. If in case not third, we can shift it to fourth again. But one of the two we will select. I mean, I'll be in touch with you on the WhatsApp group. And then once we freeze the date, we will make it as a part 2 and continue our discussion.
Thank you, sir. Thank you very much.
Over to Ramesh Bhai to conclude.
Yes, Nitin bhai. We may need part 2 and maybe part 3 also, because the flow and speed was such a good that even a common pediatrician doing mainly pediatric practice and level 2 neonatal practice, they could comprehend it very well. So thank you so much, Dr. Naveen and Dr. Ashish sir, for Dr. Wazir sir, for enlightening common pediatricians to the core. And I'm very sure that in part 2, again, as Nitin bhai said, the important topics. See, Ashish bhai, today's discussion, I must term it as one of the nicest discussion, not because it was in our program, but it was in such a lucid manner. And you covered starting from delivery room and going in a like a poetic manner. So most of the issues which you brought out, they are faced by a common pediatrician practicing especially in periphery. So thank you so much for this particular aspect. And as always, Nitin bhai is there to plan and design everything about our webinar. So thank you so much, Nitin bhai. And thank you so much our listeners who joined, and they may watch later on. We'll give them link.
Yes, this will be posted on the Gujarat Pediatrician YouTube channel very soon, and you'll be able to view it there also. And I was thinking that when we have Dr. Wazir and Dr. Naveen Jain, besides Ashish Bhai in our now sort of call in our clutches, we cannot let them go with just one session. So we will surely have one more, if not
many
two.
more things to discuss, but the time
No problem. We will discuss in the next session. No issue. So as I said, please.
Not to resonate, just to leave it like that one. That is was the chai pe charcha.
No problem. So please block either the third or the fourth Friday. I will be on touch on the WhatsApp group, and then we will declare it in the due course of time, part 2 of Pulse in Neonatology. Thank you everyone. Good night and have a nice weekend. Thank you.
Thank you so much. Thank you so much.
Thank you. You can stop recording. Thank you. Bye bye everyone.